Thank you and good morning. We are at the Healthcare Services Review Project Committee, and our start time will be 8:36. Annette, can you please take roll call?
Yes, thank you, Sandy. Supervisor Gardia? And for the record, Supervisor Gardia is Supervisor Canepa's alternate, and Supervisor Canepa is not here today. Supervisor Ding?
Here.
County Administrator Regalo?
Here.
Ms. Hopkins? Here. Mr. Brucker?
Here.
County Counsel Kiernan?
Here.
Ms. Macedo?
Here.
Mr. Wilkamp?
Here.
Ms. Valentine? Mr. Castro?
Here.
Ms. Harlan?
Here.
And Ms. Ferreira?
Here.
Thank you. Our next item on the agenda is the approval of the minutes from January 15th of 2025. I don't know if there are any questions, but if there are not, I will entertain a motion.
Motion to approve.
Anyone want to second?
Second.
Thank you, Ed. All those in favor?
Aye.
Aye.
Any nays?
I'll abstain.
You will abstain? Thank you, Supervisor Gardia. And next, we'll go over our information and discussion items. First to present is Stacy Ferreira to present the financial results for county clinics.
Thank you. I have today here with me the controller for the clinics, Rashna Sharma, who I will go ahead and turn it over to make the presentation this morning.
All right, thank you, Stacy. Hi, good morning, everyone. My name is Rashna Sharma. I'm the controller at SJ Health Centers in the finance department. Today, I'll be presenting can you hear me well? I just want to make sure I'm loud enough. I will be presenting the financial statements for SJ Health Centers for the 8 months ended February 2025. On the screen, what you are really seeing over here are the billable visits as of February 2025. Which is like trended billable visits for the last 36 months in last 3 years. For the month of February, our billable visits were 9,813 compared to budgeted 13,049 visits, unfavorable variance of 3,236 visits. Year to date, our actual visits are 79,871 visits compared to 103,773 budgeted billable visits, unfavorable variance of 23,902. Just wanted to clarify, everyone, that the budgeted billable visits does include the visits pertaining to the productivity from the vacant positions that we have at SJ Health Centers. So, which is for the first 8 months is about 24,215 visits. If you back out those visits, the 24,000 visits from the total budgeted 103,000 visits for the 8 months, you'll be at 79,558 visits, so which is more in the actuals are more in line with the budgeted visits. If you back out the visits pertaining to the vacant positions that are not filled yet. For the month of February, the visits are 9,813. If you compare them to the last 2 years, last 2 Februaries, in 2024 and 2023, the reduction is normal because February being the short month, less business days, and also the visits for the month of February in general in this year is lower than the last 2 Februaries because of the vacant positions. Again, we are trying to fill the provider positions that will help us boost the billable visits for the month. So year to date, actuals are in line with budgeted if you back out 24,000 visits that are embedded in the budget, which is kind of inflating the unfavorable variance. Any questions pertaining to the visits before I go to the financial class? Please feel free to interrupt me if you have any questions. Visits by financial class. So most of our visits are really coming from the Medi-Cal managed care, 76.68%. The next category of the visits we are billing is for Medicare, 10.97%, Medi-Cal traditional, 7.86%, commercial, 3.06%, and self-pay, 1.42%. Really no change there when it comes to the buckets. is pretty much in line with the prior years as well. So that's on the billable visits. Any questions on this slide before I move on to the next one?
I do just have one question,
Sure.
Rashna.
Sure.
I was just going to ask about the vacancies. How many vacant positions do you have?
It's a good question. So we are current, depending on what you're comparing it to is what I would say the answer, right? So, so right now we have 9 providers that we are slated to be bringing on in May, June, and July. And given those that have signed that we're hoping actually arrive, right? There's always a little fallout typically in there. But in addition, we have locum providers, which are sitting in what are budgeted positions today, right? And so we do have some here performing and doing services, but an additional group that is coming on. And those are varied, a couple IM providers, a couple of NPs and family medicine, a PEDS provider, I don't have a start date on that one yet, and then a couple more locum providers. And so, you know, our goal is to get all of our exam room space full first. So we do have 9 more coming. But of course, there's a little offset in a couple that are leaving as well, and then kind of some locum swap outs. So hopefully by July, I think we'll be at full, and we should be able to hit those numbers is kind of the goal. That's kind of assuming everybody shows up where, you know, that we have on the books today is saying they're coming, so.
Just a follow-up question
Sure.
to the county administrator. I mean, every department tells us we have 28 vacant spots. I mean, how many vacant spots do you have? I mean, it should be budgeted. I mean, you should,
They are. You know, I don't know the exact number off the top of my head, so.
within
I
10.
I can help
Yeah, I
answer
would say,
that.
do
Yeah,
you have
we
the
looked at
list?
it recently when we're going through the budget process. So just the other day, they had 67 out of their 215 budgeted positions vacant. So it's about
Okay.
31%.
Thank you.
Thank you, Adam. Thank you, Stacy. Appreciate it. Just also want to add that we had, as of February, we had 176.08 full-time equivalents compared to budgeted 213 FTEs for fiscal '24. Thank you. Next slide. Over here, you are seeing the income statements for the 8 months ended February 2025. The current period actual and current period budget original, current period budget variance original is strictly just for the month of February. The last 3 columns are actual 8 months current year actual, year-to-date budgeted original, and then year-to-date budgeted variance. So for the month of February, we have 242,000 net income compared to budgeted 210,000, with a favorable variance of 31,000 in the net income. And year-to-date net income is 2.7 million compared to budgeted net loss of 754,000 with a favorable variance of 3.5 million. So I will walk through the year-to-date column. Most of this favorable variance is really coming from the favorable variance related to the payroll costs. If you really see the salaries and benefits categories, we have almost $10 million favorable variance right there, combined 6.6 plus the 3.9, which is partially offset by the unfavorable net patient service revenue, $5.5 million, the first row. Also partially offset by the professional fees, which is unfavorable variance of 1.2 million. So the salaries and benefits, the payroll cost favorable variance is actually partially offset by the contracted medical staff. We have the locums from hired through various temp agencies like Barton and Associates. So that is some of the payroll costs that we have favorable are offset by the professional fees, which includes the medical contracted costs. Along with that, the favorable variance is also coming from our interest income for about $335,000 because of having high cash balance contained in the main treasury account. And also we have 340B pharmacy program with a favorable variance of $495,000, mainly due to the implementation of the referral opportunity program back in earlier this year. So other than that, the major category where we really seeing huge variances is net patient service revenue with an unfavorable variance of 5.5 million, mainly due to the unfavorable billable visits. So they are kind of going hand in hand. The budgeted net patient service revenue does include the net patient service revenue budgeted for the vacant positions, which has not really happened yet. So which we are hoping to get improved by July, like Stacy mentioned, as we fill the provider positions. Other than that, major categories, we are seeing some unfavorable variance on the expense side is our travel and training, dues and subscriptions. The supplies and dues and subscriptions that you are seeing unfavorable is really related to the 340B pharmacy program. As our revenues are going up, also we see an increase in the 340B pharmaceutical purchases as along with the administrative fees paid to the third-party administrators to run those programs for us. The travel and training expense is unfavorable by $242,000, and I'm talking just year-to-date numbers, is unfavorable because we are bringing a lot of locums through Barton and Associates, so they are coming from outside the state, so there is a traveling and lodging cost for that we are currently incurring because we do need to have providers to continue to provide the services because we are on the salaries and benefits, as you are seeing, the favorable variance, but it's partially really offset by professional fees and the travel and training costs. Other than that, I think those are the major variances I really wanted to point out on these financials. Before I go to the next slide, any questions? No? All right, thank you. I just went over these variances in the previous slide, so my apologies, the slide, the font size is really small, but I hope you had an opportunity to go through this slide on the handout. If you have any questions, I can answer. Otherwise, I can move on to the next slide, just to be respectful of everyone's time. No? All right, thank you. Balance sheet. So you are seeing the balance sheet. The first column is really the fiscal year 24 audited results in the first column. Then you are seeing fiscal 25 activity in the last four columns. The quarter ended September 30, 2024, December 31st, 2024. Then you have January and February numbers there. Overall, since we have just wrapped up our audits, the year has been closed. Adjustments have been posted in the books for fiscal 24. I believe the last time when the financials were presented to this group was as of September 30, 2024. So at that time, we didn't have the audit finalized. So overall results for the fiscal 24 is really current year-to-date net income for that year is $10.2 million. We had some favorable adjustments. We received $1.2 million in incentive revenue for calendar year 2023 for the HEDIS incentive payment, which got accrued as a revenue in fiscal 24 at year end. Also, there was a QIP reserve adjustment true up, so there was a reversal of $3 million that was accrued just to be conservative on the financials for the fiscal 24 prior to the financials that were presented to this group. We had a $3 million reserve that was reversed once the audit was finalized. So due to that favorable adjustment for almost $4.4 million, we see an increase there. Overall, as of February, we have cash is still pretty solid, $23.6 million, and the accounts receivable is at $2 million. You are seeing actually significant increase in accounts receivable in the February column because we just recently implemented the intermittent clinic strategy effective September 9, 2024. As a result of that, 4 clinics that had lower PPS rates are now getting paid at the clinic at those locations with the highest PPS rate that got implemented in September. As a result of that, our collections have increased, so therefore you are seeing an increase in the accounts receivable as a result of that. We are still analyzing the actual collections as a result of this implementation of intermittent clinic strategy because as of February, we only had just few months worth of data when it comes to the patient collections. We do not have enough data to really true up the accounts receivable to the number that it really should be, but we are using a conservative approach to true up our patient service revenues and the accounts receivables based on this implementation and the actual collections that we are seeing per the reports provided by EMMI, which is our third-party billing company. With this number is subject to change as the months progress. In the future, we have better data, more data, because we are still collecting for September, October, November, December, and prior months. We would like to get more data before we can actually give a concrete answer like how much of a big change we are seeing as a result of this implementation of intermittent clinic strategy. Property, plant, and equipment, really not much changes there. Other assets, we are at 24 million, which is also pretty much in line with the historical data. Accounts payable, as you can see, the cash in the first line is a little bit reduced compared to the prior months. Is basically that decline in cash is really offset by the paying off the accounts payable and the other liabilities line compared to last month. We had 1.9 million and now we are at $1.6 million in the accounts payable. Other liabilities, we had 7.8 million and now we are at 7.1 million, mainly because the January had 3 payrolls, which kind of was an inflated number, which got paid off in February. So now we are more in line with the historical trend. Deferred revenue, you are seeing $332,000, mainly because we received a payment from the health plan of San Joaquin. At that time, we did not have the details what this payment was related to. After further research, we got the information from the health plan that this is related to the gap care block excess payments for the HEDIS incentive, which will be actually reclassed to revenue and zero out this balance in March. So you'll be seeing that on the March financials. Net assets, we are at $38.9 million. Restricted net assets, we are at 1.6 million. These are actually the payments that we have received from various grant funding agencies, and these dollars have not been recognized on the books as revenues since some of these grants have actually expired and we are pending the extensions or the resolution on how we are going to actually handle these funds that we have received. But overall, we have made some progress from the beginning of the year through present. In this February, there's a reduction as we have been able to actually recognize some of these dollars as revenues on the books. Current year-to-date income is again $2.7 million that I already discussed in the previous slides. Overall, the cash position, overall the balance sheet is pretty strong. And what we really need to work on is really hiring more providers so that we can increase our billable visits and build up our net patient service revenue to improve our position even better. Any questions on this slide before I move on to the next slide? Thank you. The next slide that you are seeing is the trended cash collections for the last 36 months as of February 2025. The blue line with the solid blue line and the dotted line represents the current 12 months, the last 12 months. The orange is the previous 12 months, and then the gray line is the line that presents the cash collections as of February 2023. Orange is at February 2024, and blue is at February 2025. So the blue solid line represents the actual global collections related to the patient service revenue as of October, whereas the dotted line really represents the estimates as we are still analyzing the actual cash collections for all of those months. So we have estimates reflected from November through February. Overall, you can see that in the month of September this year, our cash collections have significantly gone up compared to the prior Septembers and onwards is because of the implementation of the intermittent clinic strategy, which helps us bill at the higher PPS rates. So that's what the really reason of the big jump in the cash collections. Overall, you can see that the February collections are estimated and lower than the prior months is because, again, February being less business days and our actually visits are lower as well, but it is in line with any of the prior Februarys in prior 2 years. Cash collections by financial class, again, we collect almost from Medicaid 95%, that's our biggest payer class. Then we have the Medicare 4.52%, self-pay 0.43%, and commercial 0.23%. So any questions on this slide before I move on to the next slide? All right, thank you. Excuse me. The benchmarks, Capital Link, FQHC benchmarks. So what you are seeing is in the last column is our benchmarks for the 8 months ended February, year to date. And column before, now we have updated those numbers for SJ Health for fiscal '24, since we now have the audited results. I have actually changed those numbers, but I can definitely provide you for comparison purposes what those ratios were prior in the previously published results. So for the 8 months in the current year, our operating margin and the bottom line margin is at 8.2%. Our days cash on hand is 190 days. Days in net patient receivables is 32. Personnel related expenses is 73%. So the greens are basically where you are really meeting or exceeding the industry benchmarks. And the reds is really the area that we need to work on. Overall, if you really look at the audited results from prior year, of course, they are for 12 months, and they do include year-end adjustments, the favorable results. The adjustments we have posted in fiscal '24, the numbers are high because of that incentive payment we received, and also we had favorable QIP adjustments throughout the year in fiscal '24, and also the days cash on hand is at 202 days. Net patient year was 35 days, and personnel-related expenses is 66%. Now, why our current year's personnel-related expense ratio is higher, very unfavorable compared to prior years, is mainly because of the year-end adjustments. When you are truing up your due from intercompany receivables, or you have other favorable adjustments that you make at year-end, your total operating revenue changes, the net income changes. That has a huge impact on your overall ratios, like the PRE ratio changes. Because we have favorable adjustment for $4.4 million really helped our personnel-related expense ratio to 66%, which was actually 72% in the unaudited results. I'm sorry. Any questions on this slide before? Actually, I'm open for questions. This was my last slide. Yes, sir.
On page 4, you explained the net patient revenue. Why? Something with this.
I'm sorry, what was the question?
Page 4 on the net patient service revenue, 27% variance. It says unfavorable variance due to business.
Over here, the variance, okay. So yes, that number that you're seeing, the 5.5% over there, sorry, not the percent, $5.5 million unfavorable variance in the year-to-date column that you are really seeing is because we have almost $4.4 million embedded in that number in the net patient service revenues related to the vacant positions. If we had hired those people, or if we had those on board, then our variance wouldn't be that bad.
So in your opinion, is it a retention recruitment issue? Or is it just the job market out there right now with professionals?
So that's a really good issue and question. I think a lot of this, occurred even prior to my arrival. So twofold. One is it's always been difficult to recruit physicians and providers into our area, and that's an ongoing challenge that I don't see us ever seeing an end of, right? So that's one thing, right? It's desirable of the area, pay rates, and that type of thing. In addition to that, there definitely appears to have been some exit of staff in prior years. I don't know that I can speak to the whys of what that was, because again, I wasn't here for that time period. But I think instability, change, and all those things over time can lead to that kind of thing. I think people are looking, particularly providers, they can choose to go anywhere they want, and they are looking for and have their choice of environments that they want to be in, right? So I think that is the piece that we can really focus on is presenting a stable environment, making their jobs easy for them, providing the kind of care that a system that a provider wants to be a part of, right? And that's the retention piece that we really need to focus on working on.
So like retention is always an issue. Not always, but it seems to be an issue.
Yeah.
Do we do like an exit interview with
You know, I can look into what data has been collected in the past. Again, a lot of that was prior to my arrival. I have spoken with all the providers that have left to date since I've been here, and it mostly has been for other opportunities. Leaving the area is what I've seen mostly, returning to wherever home is for a lot of them. And or bigger, better opportunities, right? I think we struggle with some of the bigger systems in the areas, the Kaisers and Sutters and other things that can pay a little bit more than we're able to at some times. So that's always a challenge. But for the most part, the ones that I have seen in the short 4 months I've been here have been to return to home base for them.
All right, thank you.
You're welcome.
Thank you, Stacy. Right, thank you so much, everyone.
Okay, there are no further questions. We will move on to Sam Harlan, who will give us the financial results for San Joaquin General Hospital.
Just push the middle button. So we will tell you the story of the hospital so far this year and where we expect to land by the end of the year, and just going through the budget process as well. Of course, we want to stay positive. That is always the goal, or at least break even. He wants to be more positive than break even, but the world has different things. As Rajna just pointed out, there's a lot of different factors that come in to where these numbers reside. And so the first slide, which looks a little small up there. Sorry, guys, wasn't expecting that. But this is just a snapshot of where our inpatient volume is going and where our surgeries and ED visits are going. So what we have seen here in the last, I would say, couple of years, the focus to move to more outpatient setting versus an inpatient setting. So for our discharges there, we're sitting year to date at 6,418. In prior year, we were 6,388. But we are still below budget, around 2.7%. So we've still seen the shift of where, if you will look into the surgeries we've seen an increase from prior year. This year, we're sitting at 5,109. Last year, we were at 4,904. So the surgeries is one of the higher reimbursed ones, so we like to see those. ED visits, of course, in the area that we serve, are higher than budget and higher than prior year. We're sitting at about 38,000 this year, where last year we were at about 36,000.
So I'm gonna add, just for content, two pieces to it. Surgery, we are, from a bed capacity, we always have more patients than beds. So there's not much opportunity from a revenue perspective. So we focused on surgeries. We have 7 ORs. They are maxed for the most part. We're doing, each OR should represent about 100 surgeries a month, and we're exceeding that. We've taken our 2 ORs in labor and delivery, and we always held them open for emergency C-sections. The rule is only to hold 1. So we're using now the 2nd OR to do gynecological cases in that area and trying to maximize our surgeries. We're looking at a procedure room in the new clinic with funds donated from the health plan. So we're very excited about that. But those are the areas that we can grow our revenue, and we're running into capacity issues in those areas. When you look at the emergency room now, we consistently, a number that we had never hit in the prior years was 200 a day. The ER is built for 50 patients. We're seeing about 200 patients a day. They do a remarkable job there, but it's another capacity issue. So that's why we stay focused on the things from a revenue perspective, outpatient surgeries, inpatient surgeries with a very good LOS, and any procedures that we can do. That's kind of our future, so. Sorry.
No, please jump in.
You know I will.
It adds commentary and a different point of view. So does anybody have any questions on statistics? So on this slide is a snapshot of year over year, going from fiscal year 2020 to this fiscal year, which is 2025 in comparison to budget. So for budget, we were basically, in my brain, break even at 491. That's where we're projected to be this year. You will notice some different variances. In the 2024, 2025 unaudited section, that is our current year projection. We're estimating to have 513 in revenue. Of that revenue, 285 of that is net patient revenue, collections from the services that we provide. But a large chunk of that money is 160 that comes from supplemental funding, which I'll show you. The next slide will give you a snapshot of what those programs are, and how much of a difference it makes for this facility to be able to maintain the operations and be able to continue to provide care in the community, because we do have a higher payer mix of governmental programs that don't always reimburse you as strongly as the commercial programs. So we're expecting the revenue to be at 513 with operating expenses of 532. In those operating expenses, I did not break down line by line detail for you guys, but if y'all ever want line by line detail, I can give you all of the information that you want. So if you ever have a question or want to understand something better, you can always just send me an email and I can provide you with all of the details. So we're looking on the revenue side, on the revenue side, net patient revenue, we over budgeted a little bit. Our payment rate is slightly budgeted higher than where we are generally collecting in revenue, but we were fortunate enough this year to get some supplemental funding increases in QIP and EPP programs that are about $30 million to help offset the expense side of the world. So we're expected to be around break even, which is on this slide is projected to be around 264,000, but that's break even in the world of numbers with this many numbers. So, and then we're budgeting for next year to also be around the break even point. We just had our budget meeting yesterday, went through those details. So there's some adjustments that need to be made operationally to be able to make those numbers happen, because we've had some large increases in salaries, wages, and benefits. But we're prepared, as Mr. Castro leads the hospital down the road, to make those adjustments to make sure that we stay break even or positive.
So just from a labor perspective, the two union contracts are an increase to us of about $40 million. We believe we can overcome those increases, but that's where the bulk of that increased expense is coming from. From a nursing perspective, the difference of where we stand today versus where we stood 3 years ago, and this was a tough contract, and Jennifer's team did a great job getting us to where we need to get to. From a nursing perspective, we are now sitting competitive, and we're a little bit lower than our Common Spirit friends, and a little bit lower than our Kaiser friends, but not 20%. So there is a want to come to San Joaquin because it's more of an altruistic opportunity, and now that we're competitive up and down from the beginning wage to the advanced wage, we have no travelers. We actually have a number of applicants, nursing applicants, that would like to come in that we can't accommodate, and it's a good space to be. So I think that the opportunity, even though we see a significant increase, will be offset a little bit by some temporary labor, most importantly. But here's the big ticket that you can never really put a dollar sign on. Prior to us getting the contract, our turnover rate, and especially our turnover rate in that 0 to 1 year, was like close to 40%. Now it's 8. And if you think about every time that you bring in a new nurse, especially a brand new nurse, you really get you don't see a financial benefit. I don't want to say you get no value. You don't see a financial benefit
3 months orientation
until they're 3 or 4 months in, and we are losing them at 4 months. So the opportunity from savings really comes from an orientation perspective, and we'll be able to get you those numbers as they progress.
And Rick and
So-
Sam, I'm sorry, go ahead.
No, go ahead, Sandy.
I was just going to ask if you can let the supervisors know and the committee know, as far as vacancies for the nurses, where they were a couple of years ago even, and then where they are now.
So in 2022, when we came here, we had 320 traveling nurses. 320 traveling nurses at wages over $200 an hour. We have 0 right now. I think we are bringing 3 back for a short stint from an ER perspective because we're putting a lot of new nurses into ER and we want to train them appropriately. And so we've done a really nice job in completely removing that, what used to be a pretty mainstay for the hospital in regards to travelers. 300 when we got here, 0 as we speak, and we're very proud of that. Thank you.
CIO Regallo, I can actually provide some numbers as we're getting ready to take the MSA to the board. When CEO Castro started, just not including travelers, the nursing vacancy rate was 22%, and that was driving up those traveler costs that he was just discussing. And according to HR, the current vacancy rate is 5.6%. Yeah, this is just for our nurses.
And just for comparison, the national average for nurse turnover is about 18%. So we've done a really nice job there.
Thank you. Supervisor Dean.
I just wanted to make sure I heard that correctly. I mean, congratulations to all. That literally is amazing. I didn't realize. Wow. Okay.
So just so you know, when I got
Congratulations.
here, that was you're right. I mean, that was a scary number.
Yeah.
That 302. So they've done a nice job.
Well, and Rick, correct me if I'm wrong, I know we focus on the financial issues here, but it's also presumably much better for patient care if we have consistent employee nurses and not travelers.
You know, what we committed to from, and you'll see it when we present the MSA, but what we committed to coming here is, and all of our employees know we're going to fix the financials first. We're going to focus on quality. And we've seen, and I know that's not part of this meeting, but we have seen every indicator in regards to pressure ulcers, in regards to falls, in regards to all of the things that you don't want to happen at a hospital decrease significantly. And when you look at central line infections, urinary tract infections, for the most part, they're now sitting at 0. When we were looking at 18 to 20 a month, so.
And that will presumably help our leapfrog score.
Yes.
Sorry.
Why are you apologizing? Any more questions on that? No? So this slide is what I was alluding to earlier. This is our supplementing funding sources, which we rely heavily on. So we sometimes our balance sheet doesn't look so great because we have to pay in large IDT payments and wait 3-4 months for that money to come back around. But we're starting, we've seen our dip and we're starting to see the funds start to come back in and flow back in from the different programs. So this is what we rely on, and we monitor it very heavily on whether or not we're going to meet these various, each one of these have a nuance of what is required. Some of them is for state-only California, Medicaid or Medi-Cal in California. Some of it is from getting points from quality scores, like for our QIP, and making sure we make the indicators that we need to make. So it comes up from various different areas, but for us, it is estimated to be $160 million this year for us, and we project in budget about 154 or above. We did see in this current year, which was nice, a increase in 2 of our programs. QIP increased to 75% and EPP increased to 25%. So that's around $30 million that we were able to book this year that we needed to make sure that we're going to get to where we need to be this year and next year. So these programs are very, and I'm sure if you've been in a board meeting, you've seen certain contracts come up. We do hire a company that helps us manage these because there's a lot of data that goes into being able to submit this and make sure that you stay on top of things and that we have the right places in our programs for the quality to monitor those things to make sure that we can receive the maximum amount of funds for these. The concern from us right now for this year and this next fiscal year and then a couple of years later, because we're about 2 years behind in these programs, is we don't know how the federal government is going to affect these fundings. Because if they change the FMAP percentage that we get and we get a decrease there, we can see millions of dollars sort of vanish from our buckets that we use to treat patients currently. So this is a focus for us. We literally meet weeklies, monthlies, to make sure that our team is doing everything that they need to do to submit the information and that we receive these funds so that we can continue to help patients.
A point I want to make to the board members is, the discussion a lot of times is the difference, let's just say, between the county and the publics and the privates. So if you look at that number at 160 million, it's needed because when you look at what Medi-Cal pays us, it's about 9 cents on the dollar. When you look at the potential of, if you look at the potential of the public hospital, in a sense, going private, either being bought or sold to another company, all of those funds go away. And so the big challenge that we have, or the big opportunity that we have as a public hospital, is these funds are our lifeline. The challenge as it translates to the private sector, they also receive public funds in the form of QAFs, but you know, Joe's is about 4 times as big as us. Their QAF fee is much smaller than this. So and all I'm trying to point out to the board members, the need to stay a county hospital is because of these funds right here. That don't exist for the privates or the not-for-profits. I don't believe any of the 21 county hospitals could survive without them. And the difference between what the publics and the privates get from their government entity, which is the QAF fee, is significantly less than what we see here on the public hospital side. Does that make sense? Yeah. Okay, good. Thank you.
Does anybody have any questions on supplemental funding? We can meet and we can discuss for 3 hours if you would like. There's a lot on here. So this next slide is just to give you some idea of what we're working on at the hospital. We're working on a lot, and we're trying to make a lot of improvements. We're trying to be able to capture our data in ways that we can use it to manage operations in real time versus at the end of the closed month where all those numbers are behind us now and we can't affect those numbers. So we're trying to be more proactive in the things that we're doing. So we're still in the throes of a time clock system. Hopefully that will be done this fall. That's been a major project with all of the MOUs and that's associated with the county and the hospital. It's really hard to tell a computer what it needs to do. So, but by the fall, we're expecting that will allow us to be able to get time data to our department managers and then eventually load it into a system to where we can see what the scorecard is for the staffing in the area. So right now we're sort of, we fly blind, walk through and check, but we'll have more data with this system coming on board. So, and as the people in the county already know, Workday financials are on the way, which we will be happy to say goodbye to old PeopleSoft and to work in a system that is a little bit easier to work with. StrataJazz, which is we currently use EPSI, but it's basically an operationals platform, so we can take the information from Cerner, which is our EMR and patient data, our GL, which is PeopleSoft now and will be Workday. We can combine it into a depository and be able to create some real game-changing things for operations. We will be able to provide cost accounting that we currently do not have, which will be a requirement next year. We have to actually implement a cost accounting system in order to keep the $160 million. So that'll be a project. In that project, it will also contain our budgeting. We will be able to also do operational dashboards for the team for either productivity in a department to see how their staffing is working or what their utilization is in any department. And then the executives can drill down from a graph all the way down to department level or patient level or employee level. Another exciting thing is the SSI billing software implementation. So we're currently on FinThrive, which is not a robust system. SSI is a nationwide system that I've used at various different hospitals. We will be able to process our claims faster, quicker, cleaner, and get reimbursed in a more timely manner. So we're excited about that. Cerner will be updating our patient accounting system to an OPA. That platform is basically just to transfer what we have in Cerner. We're not getting a whole lot of functionality out of that, except for the next one, which I'm very excited about, which is a patient accounting contract management. So we will actually have the ability to look at reports that tells us if we're overpaid, underpaid, not paid, the reason why, And we will be able to do that in real time, follow up, have the data for, right now, collectors have to go out and actually pull up and manually do these things. It will be a report that they see every day that they can follow up with their payers in a timely manner to get the cash in the door. Solventum, which is now Solventum, used to be 3M. If you've been in healthcare for a while, they were purchased, so it's not a name I'm familiar with. But we're doing computer-assisted coding, which will also increase our discharge final build numbers to get the bill out the door quicker. It's basically using the computer-assisted AI knowledge to be able to code not all patient accounts, because some of those are more difficult and they won't be able to be done by AI at this point in time, but some of the easier ones can get through the system and get reimbursed quicker. And the last one is QSite, which is where we're working on this high inventory management system that will be in conjunction with Workday. That inventory system, currently we keep track on a Excel spreadsheet, which is not optimum. So this will give us the opportunity for our high dollar implant cost to be able to track that inventory in real time and to make sure that we don't have any hiccups in the inventory system to where a screw gets lost and then we have to pay for it.
So Sam, for your cost accounting needs, are you guys looking into the capabilities of Workday to be able to provide you what you need? Or is this going to be in conjunction
This
with
is in
that?
conjunction.
Okay.
So it's basically, we're creating our cost report in real time where we only do it one time a year, right? Which is the big books or whatever. So we'll be building into the systems all of those things so that we, at any time during the year, we can do that. And it does function with Workday. I made sure that they had implemented with them before. And they also work with other public hospitals,
Okay,
which
good.
was a plus because the public hospital is a little different than just. a
Yeah,
regular
because
hospital.
Workday is, at least our implementer is boasting about its cost accounting abilities, so
Yeah.
just wanted to make
This
sure.
one goes a little bit further
Yeah,
than that
okay.
one. Yeah, this one goes a lot down further. I will actually be able to, if Rick said, hey, he gives me 3 physicians, and they all do the same procedure, I could tell him each one of the cost associated with each one of those, and whether or not they use the OR more or less. Do they use more supplies or less? So that they can make some judgment calls
Got
on
it, got it.
operations.
Okay, thanks.
So.
You know, I think one more piece that I want to add is we have been very fortunate over the last 6 months in regards to physician recruitment. So we had 6 identified specialties that we needed to fill. The biggest one was peds, and we've successfully filled all of those positions. The two places that we still have some opportunity is family medicine. We have a number of potentials there. And the one that we just can't ever find, and I don't think they exist in San Joaquin County is we can't find a psychiatrist to save our lives. So that's a little bit problematic sometimes in regards to some of our mental health issues that we have in the emergency room. But we have been fortunate to urology, general surgery, like I said, the pediatrics, a couple of family medicines, and I know I'm missing a couple other big ones, but we have a hepatobiliary surgeon that we brought from Southern California, involved in transplants, but really involved in liver issues. And it's a huge opportunity for us because of the prison contract and the number of liver issues that they have in the prison contract. So we've brought in some really talented guys, and we're really excited about that. Our urologist, he's a breath of fresh air. He sees about 50 patients a day, which we're trying to use him as the example for our other physicians. And his request for us is bring me more. So he's done a really nice job for us. We've been fortunate that way. So.
Anything else you want to add to this?
Nope, I'm good.
No?
I'm good.
You just want me to stop talking?
Never.
Do y'all have any questions?
Yes, Supervisor Gardia.
So for the general hospital, what's the percentage of Medi-Cal, Medicare patients? 'Cause you said
Oh,
you
we
get-
have, yeah, it's in the 70s to 90 range. For Medicare is about 20, and then Medi-Cal is 60 to 75, based on wherever the money
So
goes.
it's pretty much similar to the clinics?
It is,
Little
Yeah.
less than the clinics from a
yeah,
medical
a
perspective.
little
We
less
get a
than the
bit more.
clinics. We do have some commercial, right, but
So-
not as much as the competitors down the street, but,
Our
It's a
commercial,
small
our commercial
percentage.
really comes from trauma.
yes.
That's where our commercial goes. So when you look at our general population, I believe the number is 74% managed Medi-Cal. Or is it- Yeah.
Can you please speak into the microphone?
sorry.
Oh, sorry.
If you look at our payer mix overall, our real basic clientele for what we deal with on a day-to-day is about 70 to 75% managed Medicare, Medi-Cal, which is health plan, about 5% of straight Medi-Cal, about 28% Medicare, which we're blessed to have, probably 5% commercial. But the commercial is really important to us. The commercial mostly comes through the trauma services, and there's a lot of things I'm proud of at the hospital. The trauma services is one of them. We received significant traumas on Friday, as you all are aware of, and all of those people not only survived but left the hospital or discharged from some very serious stuff. That's where we get our percentage of commercial contracts, and those contracts for us are very, very well paid. So trauma center's been critical for that.
And CDCR is a contract
And
as well.
CDCR as well, yeah.
Did that answer your question?
Are there any other questions? No? Thank you very much. And, okay, moving on, we have Brandy Hopkins to give us an update on the county's healthcare system.
Thank you. Good morning. We're going to shift a little bit from financials and talk about where we are overall with the county's healthcare system. The Board of Supervisors has tasked the County Administrator's Office and all of our healthcare departments to work together to look at integration of the healthcare system and really stretch our ability to maximize funding streams that we'll talk about a little bit today. And you've heard both the clinics and the hospital talk about the supplemental funding. But look at how can we reduce costs but continue to provide high quality care, and really looking at all of our partners in this process of providing high quality care to the underserved in our community. So I'm going to touch upon this more in depth in a few minutes, but one of the important goals of ours is to facilitate a cooperative relationship with one of our outside partners, which is the San Joaquin County Clinics Board. They are our HRSA designee over the county's clinic system, and we'll talk about some of the changes coming up with them in just a few minutes. But it is important to acknowledge that as we look at integration, that we have external partners as well. We are working with our healthcare departments, so healthcare services, the hospital, and the clinics, to continue to provide the high-quality healthcare services that I mentioned a minute ago. And we are constantly working with the health plan of San Joaquin, and in some cases, other counties as well. We have some partnerships with Stanislaus County and some other counties where we're really still trying to focus on high-quality care with that overall focus on population and community health management. And then, as I mentioned, we really want to position our healthcare system for future reimbursement models to make this cost-effective and sustainable in our community. Director Valentine couldn't be here today. She has jury duty. So she was going to touch upon some of the things that her vast divisions are working on, and we do have Assistant Director Matt Garber here to help in case I need his assistance. But we're all familiar with the Be Well campus. That'll be before, parts of that will be before the board with some recommendations on April 22nd. And then one of the big initiatives that they're working on right now under Correctional Health Services is to align mental health services supervision under behavioral health and not under correctional health, but remain that the medical and substance abuse services remain under the direction of correctional health. And we'll have Director Valentine touch on that next time when she's here. And then there's a potential move for veteran services, which is exciting. We may be able to relocate them to a place closer to the French campus, which is also where the VA clinic is, to assist our veterans with their healthcare needs in the community. Many of you are aware we have a management services agreement, or an MSA. So Supervisor Ding will ask me for my dollar for an acronym. With the hospital.
Hey, interrupt you.
I
This
know.
list you
Yes.
had of all the names and acronyms,
I know.
that's going on my wall.
Okay.
Thank you.
I'll give you a key and I'll pay my $5. I may owe you 10. So in 2022, the board made a special finding that a management services could maybe potentially be provided more efficiently, effectively, and economically through a management services agreement with Common Spirit or Dignity Health, depending on what term that they're using. And the board approved an initial 18-month term. And they really focused on quality and financial improvement. Our current agreement expires on June 30th of 2025, and the county administrator's office has been working with CEO Castro, and Common Spirit, and we will be recommending a 3-year extension to the board on May 13th. There's only 2 minor additions. Common Spirit and the county administrator's office meets quarterly, and that we'd like to continue to do that. And then county counsel's office and the CAO's office is working with Common Spirit to look at a community board of advisors with some delegated oversight, really related to credentialing and quality, so focusing on the medical side. Quinnie, is there anything you'd like to add to that?
Nope, not
Okay.
at this point, other than that the community board would give us some flexibility to handle matters in closed session, which really belong in a private setting. So we do hope that we can figure out a way to make that work.
Thank you. So this is really exciting. So far, 2 board members in the room. We will be bringing the recommendation to you on May 13th with an actual in-depth presentation from Common Spirit on the approximately $50 million in savings that we've received so far from the agreement. So that'll be, I think, an exciting presentation of the partnership between our general hospital and Common Spirit. Okay, so I'm going to spend a few minutes talking about the clinics, or by their proper name, SJ Health. And this is where we are also bringing some updates to the board shortly, some recommendations. But our clinics have 7 primary care clinics, and they are our federally qualified healthcare center lookalikes, so FQHC LALs. The county is the designee of the FQHC, but we need an outside partner in order to meet the qualifications to have the FQHC designation. And so the clinics are jointly operated by the county and, as I mentioned a minute ago, the San Joaquin County Clinics Board, which is a 501c3. And the county created this for the sole purposes of acting as the co-applicant. So that we need them because our Board of Supervisors doesn't meet the criteria that HRSA has for a community board to oversee the clinics, which is 51% patients, and some other, there's a minimum of 9, maximum of 25, and our board doesn't meet the criteria for that. A governing document called the co-applicant agreement governs the relationship between the county and the nonprofit. I mentioned HRSA a minute ago. They recognize and provide our designation and determine our eligibility. This provides much higher reimbursement rates for the county than we would receive if we were not designated as an FQHC. County administration has expressed longstanding concerns about the effectiveness of the management at SJ Health since the 2021 co-applicant agreement was revised, and that is what we'll be providing an overview this morning, and also to the Board of Supervisors with recommended changes on April 22nd. There are some difference in FQHCs. So we are a public agency FQHC, which would be different than for members of this committee that are familiar with CMC locally or Golden Valley locally. They are not a public sector FQHC, and so their rules are slightly different. As I mentioned a minute ago, having a qualified board of directors is one of the requirements from HRSA, and our Board of Supervisors doesn't meet that particular criteria, mainly as we need between 9 and 25 members on the Board of Directors, and 51% of the Board of Directors have to be patients of the clinics. And so our board doesn't meet that criteria, which is why we have delegated the function to the SJCC Board of Directors, the nonprofit. And as I mentioned a minute ago, they were created for the sole purpose of acting as our co-applicant so that we can meet the HRSA designation. The county is the HRSA designee and holds all assets related to SJ Health. So the buildings, the equipment, the employees are all county-owned assets, as we are the designee. If we become a 330 designee, which is a slightly different type of FQHC, we still would be a public 330 designee, and these requirements would still apply. It wouldn't change the governing relationship. Okay, my little clicker's not working. do this. Got it. Okay, thank you. Thank you, Robert. So as I mentioned a minute ago, we are considered a public agency, FQHC, and the HRSA recognizes that public agencies must comply with federal, state, and local laws that may not apply to a non-public FQHC. And this has really been the concern between the county and the SJCC board since there were revisions to the co-applicant agreement in 2021. So HRSA recognizes in multiple sections of their HRSA compliance manual that if the public agency is, they call it here, the recipient or the designee of the federal award or the FQHC designation, that the county or the public agency may establish and retain the authority to adopt and improve policies that support financial management, accounting systems, and personnel policies. The 2021 revised co-applicant agreement contained some inconsistencies and confusing language, which created situations in which SJ Health was not necessarily complying with certain county rules, such as our procurement processes, and that is what our office has been working on with the SJCC board to correct in the proposed co-applicant agreement changes that we are bringing before the board. See if I can do this. There we go, it's magic. Okay, so summary of those changes, they were approved by the SJCC board on April 9th of 2025, so earlier this month, and I mentioned a minute ago that we'll be bringing it to the Board of Supervisors on April 22nd. There are some structural recommendations. One is to organize SJ Health under Healthcare Services. This would be a dotted line reporting relationship as the project director of SJ Health needs to report to the SJCC board as a HRSA requirement. But what we are hoping to do is to organize SJ Health under Healthcare Services to provide an umbrella department for SJ Health that can provide support for larger projects, provide support towards the county as an institution, and keep them close to healthcare versus lately, mostly this has happened through the county administrator's office. We do have a recommendation to eliminate the liaison committee and instead create a search committee for a project for the hiring of the permanent project director. And the search committee would include 2 members of the Board of Supervisors. Currently, that is Chair Canepa and Supervisor Ding, 2 members of the SJCC board, and then the county and SJCC would mutually select somebody from the medical community to participate. Just a minor eliminate references to this particular project committee, not because the project committee is going away, just so everybody knows, because it doesn't belong in an agreement with an outside entity when it's an internal committee, and then really strengthen the county's authority to allocate and disperse supplemental funding, which is outside of HRSA's scope. We'll talk about that in a minute. Clarifying recommendations to clarify that the county is the HRSA designee. That's missing from the current agreement. And then require that SJ Health participate and inform the county regarding operations. The operational investigation that occurred showed that that was not happening back in 2001. We want to continue to work on clinical integration between all of our healthcare departments, and then clarify that county's fiscal and personnel policies apply, and then simplify the dispute resolution language. Are there any questions? So tying into the co-applicant agreement is the SJ Health Memorandum of Understanding, or many of you in this room have heard it referred to as the MOU. This covers various operations of the health clinic system. Really, it talks about what scopes and services are provided by other county departments to SJ Health. Once the co-applicant agreement is approved by the Board of Supervisors, some of the services outlined in the MOU may no longer apply. The current term is 60 months. It expires on June 30th of this year. It's self-renewing for an additional 5 years. The county administrator's office will be putting the affected departments on notice that we need to redesign the MOU, in part because some of it is outdated, in part because it outlines how supplemental funding is divvied up, and we need to revisit that. We'll talk about that in a minute. So it's time to refresh and redesign the MOU. So this ties into what both the clinics and the hospital were talking about a little while ago. The supplemental funding or the quality incentive program, often called QIP or QIP. So public healthcare systems are eligible for federal QIP funding, or you saw Sam's chart a little while ago. There's lots of other types of funding, but I'm familiar with QIP. This is outside of HRSA's scope, and this has been something that has been not clear to all parties. So we want this to become clear that QIP is outside of HRSA's scope. It's subject to Board of Supervisors' policy directions, and that we will be bringing forward, at least annually, our recommendations collectively as a healthcare system about how QIP should be divided between county departments. Currently, the MOU allocates 36% of QIP dollars to SJ Health and the remaining to the hospital. And we really want to look at something that aligns how the dollars are divvied up based on need, based on quality, and based on participation. Okay, so just wrapping back up, we want to continue to work and provide aligned incentives between healthcare services, SJ Health, and the hospital to further our goal of providing quality healthcare services, and really start focusing once the MSA and the co-applicant agreement are approved by the board on that broader and more effective health care delivery in our community. So quality, credentialing, integrated services, and our financial performance so that we can remain focused on population and community health and really be focused on our patients. That is our main goal. Okay. And we are open for discussion or any questions.
I just want to point out that, one of the challenges that I think from a hospital perspective in the MOU is really between the hospital and the clinics. I was, you guys all who know me for a while, I wasn't happy with the separation. I wasn't happy with the way that it was, because I see opportunities from a cost perspective that I think we can do much better at. But more importantly, in September of 2022, when we felt, taking a look at the MOU, that it wasn't in the hospital's best interest, we went to do the 60-day or six-month no fault out because we wanted to renegotiate. And this is not being disrespectful to anybody. Everybody's working hard. So we have an agreement between the hospital and the clinics. The clinics could decide at any time with a 6-month agreement that we want to get out, but the hospital wasn't privileged for that. So that arrangement was between the county and the clinics, and I believe the hospital should have a say in that as well.
Are there any further questions or comments? Okay, none. Thank you very much for the update.
Thank you, Supervisor.
And that brings us to committee comments. So if any committee members, oh, sorry, I skipped over public comment. Annette, can you tell me if there's any public comment?
And there's no public comment.
Thank you. And now it brings us to committee comments. So if there are any members who would like to make any comments? No? Okay, seeing none, there are no closed session items scheduled for today. Our next meeting is scheduled for July 16th, and we will adjourn at, what time? 9:44. Thank you.